Thank you. That was wonderful. If you could stop sharing, great. That's perfect. As you can see the chat, yes? Okay. If you want to answer the questions, we have quite a few questions for you this morning.
Okay. Can you hear us okay? Okay, good. What is my favorite part of the day? That's so hard. I really think for me, my favorite part is just getting to see patients kind of progress. And sometimes it's progression over an extended period of time. Sometimes it's progression within a session. So you can have someone come in, they've been doing really well, and then something happened over the weekend, or they moved funny at home, and now their pain is significantly higher. They're having a harder time. And so you get to try and kind of figure out what is going on in that moment. It's to see how we can improve their pain, how we can improve their function, what's going on. And so for me, it's really getting to watch our patients improve, and just to get to talk to them and get to know them. You know, you get to really, like we were saying in the videos, you build relationships with your patients, and so you get to learn from them and to talk to them and just enjoy their time. And so for me, those are kind of the things like I enjoy a lot.
I'm kind of in agreement with Sarah, but you know, for me, I guess based on my area of work, I've always worked with chronic conditions. So I have often, you know, found joy at the end of the whole thing where a patient has achieved something really spectacular. I don't know if we have, how much time do we have, ma'am? Do we have a few more minutes?
As much time as you want. That's how much time you have.
I'll just tell you a story. This was in long-term care. I had this young lady. She was in her 30s. She ended up with a really bad traumatic brain injury. The mom had to decide whether they have to pull the plug on the ventilation. And the doctors told the mom, if you do it, she's going to go. But the mom said, go ahead and do it, because I don't want to see my daughter this way. This lady is here in the valley. Well, sure, to make a long story short, she ended up at my care facility. She did not have insurance. So all the PTs, PTAs, the occupational therapy staff, we all decided everybody's going to pitch in 30 minutes a day, just as pro bono. We spent 2 years with her. She's now driving a car. She's living in an apartment, and her kids have graduated from college. She cannot walk. She is in a power chair. But from being unable to speak to going to that point where she can feed for herself, she can dress, you know, she's got limitations in life, but she can turn on the TV, she can, you know, do basic care for herself. She has a provider, she's able to control and help, you know, things going on with her kids' lives. Is it the best outcome under the circumstances? Yes. Remember, at one point they told she's not going to make it. So that took 2.5 years, and it took a lot of work from almost 16 individuals. We had occupational therapists, occupational therapy assistants. We had, you know, assistant staff like technicians. And where I worked, we did pro bono literally for 2.5 years because she had no insurance. Everybody pitched in. So that was one of the most rewarding experiences for me. So I cannot say that's a favorite part of the day. There were days I would be like, is it even worth it? You know, you think about it humanly, but then things happen. So we had to kind of like go with that. That's something that stood out to me.
Yeah. That's amazing.
And one part of our job is to really interact with the patient and have them come up with their goals. So patients will come up with goals of, I want to be able to reach into the cabinet. I want to be able to brush my hair. I want to throw a football again. You know, it's over a varying spectrum depending on where that patient is in life. And so our job is to help them reach those goals and to improve how they're moving, what their function is, how their daily activities, what they're doing to reach those goals. And so that's a really rewarding part of what we do, is helping patients kind of reach those things.
The question, is it difficult to keep your patients motivated throughout their journey? Yes, it is. If yes, how do you overcome this? That's why I said you got to be patient. Nothing in therapy works overnight. It's not a magic pill. It requires patient involvement, and your role is to be the cheerleader for the patient. Basically, that's what it is. In every form, you're the cheerleader. Sometimes you might have to make phone calls. Hey, are you keeping up with this or whatever? You have to have the desire to stay on top of the patient's progress, and that's the key.
Yeah, and really just encouraging them kind of where they are, so people will have better days, they'll have worse days, they could be doing really well, then they have a setback or they have a plateau. It's very common in therapy for a patient to be doing well, then they do flat for a while, then they plateau again. And that can be incredibly frustrating. Patients will come in and they're like, I don't understand, I was doing so much better, like what happened? And you have to, and that's where our education comes in and explaining to him, this is how tissue healing works. This is where we are at this point. We can't do these activities yet because you have this, and this restriction to allow for proper healing of the bone or the muscle or whatever it is that was repaired. And so, like Preeth was saying, so much of what we do is encouraging them and telling them, like, this is where you are. This is what we're going to be working on to get you to these things. This is what's going to be working to help improve this. And that's why our education is so vital in what we're doing, and patient education is so vital in teaching them why they're doing the exercises, what the exercises are actually doing for their body, how it's going to help their movement. Because you can have people who will come into our evaluations and they don't want to be here, they don't care to be here, they're here because the doctor sent them here. And so we really have to explain to them, this is what's going on, here's how we can help you, this is how we're going to achieve these goals, and take them through that, and you walk alongside them with it. And so, like Preeth was saying, you have to have a heart for people, because there are days it's going to be very frustrating, because you're going to have times when you feel like the patient isn't getting better. They're frustrated, you're frustrated. And so you really kind of have to take that in and internalize it and just know that you're doing the best you can for them and they're going to get better. And so that really helps. And one of the questions I think we missed, like, how has technology changed PT over the years? That's something that even just in the time that I've been at, the advancements in what we have as far as technology is off the charts. So we have blood pressure cuff machines that even a lot of pro and college sports teams are using right now to really help. So with an ACL surgery, a lot of times, or if it's an ACL meniscus repair, they're not weight bearing, you can't do squats. And so what happens is you're going to have a higher rate of muscle loss. You're not going to have as much loading through the bone and through the muscle. And that's how you get strength. And so what it does is it lets us put compression around around their leg, around their arm. And it occludes some of the blood flow going in and out of that extremity. And what it's doing is it's sending a ton of kind of pro-inflammatory cytokines, proteinogenesis cytokines and minerals in tissue to help produce muscle growth without actually being able to load the muscle to what it actually requires for true muscle growth. So to get muscle growth, you have to have 70 to 85% to 95% of a 1RM. You have someone who just had surgery, they can't go squat their 1 rep max. That's not possible. So this lets us do that at a much lower rate, but still get those gains, which typically aren't seen under a normal circumstance. It's also, there's a ton of analysis technology. You can set up cameras and analyze how someone's walking, what, like, kind of biomechanically what's happening, what's functioning, to allow us to see, okay, they're internally rotating their hip here and they're not fully extending their knee here, and then letting the patient see that. Virtual reality has become a huge portion in their geriatric population, and amputees. A lot of times they'll put the virtual reality on someone who's just had a prosthesis. So they had an amputation in their leg, they get their new prosthetic limb, and to help them walk for the first time, if they can visualize themselves walking with 2 feet in the sand, on the ground, it helps them overcome some of those mental processes to allow that to function more.
Actually, to add to what Sarah said on virtual reality, I have a friend. That's all he specializes in. He is working on head injury patients, comatose patients, and extremely ill stroke patients. All he does is virtual reality from the first day. As soon as they come out of the time where they're like kind of stabilized medically and everything is kind of okay, where they are out of danger, they start virtual reality right away. And that's all he does. He prepares them for the futuristic rehab. So that's his specialty, and that's all he does. And studies have shown that those actually promote better neuroplasticity, better neural outcomes. So yes,
one of our acute kind of care rehab, neuro rehab, they actually have exoskeletons. So what it is, it's like basically a bodysuit. And for people who've had a spinal cord injury, they're not, they have decreased activation in their legs. They don't have core stability, or someone who's had a stroke. We can actually put them in, and it goes over their entire body, and it walks for them, or it helps them get in and out of chairs. And so what it's doing is trying to rewrite kind of those neural pathways, get those signals back into their spinal cord, into their brain, to allow them to have kind of rewriting of those motor programs and to have neural growth. So a nerve only grows a millimeter a day. It's so small. And so we have to get everything kind of firing again, reteach the body how to do those things, to allow them to be able to walk again in the future, or to be able to get out of a chair to transfer to their bed. That's so huge in terms of what a patient is able to do in their quality of life if they can transfer independently from their chair to the bathroom by themselves. And it helps their caregivers. So a lot of it is caregiver education, how we teach the people taking care of these patients, so that they're in a better position to do it. They're not going to get hurt. And so that's kind of a little bit about how technology has helped it. And then again, it just plays back into how we're evidence-based. Preeth mentioned it with research. We study research, because we always want to be giving our patients the best, highest level of care that we can. And so we need to continue to advance in those things.
There was a question from one of the students that said, how do y'all challenge your rehab skills with thinking outside the box and patient-specific instead of treating on? Actually, we don't treat them the same. It might seem for the common eye that we look at it as the same approach, but when and where to progress requires a lot of clinical reasoning. It would be hard for me to cover the depth of that answer in this little time, but truthfully, orthopedic cases are totally dealt differently from neurological cases. Developmental delays and milestones are dealt with totally different. So when you go to PT school, whether it's PTA or PT, or occupational therapy, or the assistant, or the OTA school, remember you're going to have to understand that you got to have competencies across the whole spectrum of life, from an infant to the very elderly, frail, on hospice, home health. So if you like sports but you think you can only do sports, then you cannot finish PT school. PT school requires you to do pediatrics, orthopedics, neurology, cardiovascular sciences, the whole spectrum. If you like just neurology and you don't want to do the rest, you cannot finish PT school. You're going to have the competence of the whole thing. Yes, once you come out of school, we have likes and dislikes. I don't think I'll ever fit into a pediatric setup. That's just me. So somebody asks a question, is it difficult to be positive when you see that the patient is negative in the process? I don't think I'm fit to be able to handle a situation where a mom is, anxious over the child's health. So I think, and like today, I handed over a patient to Sarah. I said, Sarah, I need your help with this lady. And this was just this morning, because I knew there was no way I could address her needs. And being able to read that from the beginning comes with time. So as soon as you engage with the patient, this patient's personality will suit somebody else. And quickly I was able to figure that out, and I said, this is for Sarah. I was giving her, as soon as she walked in the door, I said, this is for you. So that's the key. Is it difficult to be positive? Sometimes it is challenging, but overall, it's a good experience.
Yeah, and to go back to the one with challenging your rehab skills, so you learn in school, this is how this presents, and this is how someone who has a lumbar problem is going to present, their shoulder pain is going to present this way. You'll realize the first time you're in the clinic, people hardly ever present like that. So you can say you look for these, and these signs. Well, you may find 2 of those, but then you find 15 other ones. And so you're constantly having to assess the patient. Every time you see them for a treatment, there should be a portion of evaluation, because you never know how they're going to be different that day, what's going to be happening with them in that time, in that moment. And so we constantly have to be using our clinical skills, using other things we see in the clinic to be treating our patients. And so I've had a patient who tore her ACL. She did great, rehab, she did phenomenal, went back to sports. A year later, she tore her other knee. So she comes back, and the way she responded with her first knee was not the way she responded the second time. And you find that with people who have bilateral knee replacements, or they have right shoulder pain and they have left shoulder pain. Just because both legs were hers, she did not respond the same. And so you're constantly having to assess the patient and what's going on, and to think outside of the box to get their muscles to activate the way you want them to. Because for me, I can tell someone to squeeze their shoulder blades back and they can do it immediately. Preeth can have a patient and they tell them to squeeze their shoulder blades back, and it's like you're talking to a wall, like nothing's happening. And so you have to use a lot of different techniques. I'm a huge believer in, if I'm an orthopedic therapist, I have to be a neurotherapist too, because people want to silo out all of the different settings, and you can't do it, because an orthopedic patient has neurologic problems. Their nerves are still controlling their muscles at the end of the day. And so if you don't know how to address those things and how to activate those things and to use those tools, you're gonna have a harder time treating the orthopedic conditions, and vice versa. If you have a patient who had a stroke, they're gonna have right shoulder pain because they don't have the muscular strength there to stabilize that shoulder when they're moving it. So you can be a neuro patient, but you still have to treat a portion of orthopedic conditions. And so Preeth was saying, you have to know the spectrum to get out of school. For me, I feel like I have to know the spectrum to treat my patients even outside of school. And so it really is challenging mentally sometimes to get patients to do what you want, but it's so exciting because you can learn, like you're continually learning, because you learn, okay, this worked for this patient, I'm going to try it over here with this patient, and it works too. And you find tricks and techniques to help people get them where they want to be going. So it's never the same. Every day you may have the same list of patients, but it is a completely different day just because they're all different.
On another note, there was a question about technology. I want you to know you can do physical therapy without any gadgets. I mean, literally, you can have absolutely nothing, just the patient, his home environment or her home environment, just a bed or a mat, and you can do therapy. So you should be able to be flexible and adapt based on the clinic setting. Technology does not bring necessarily improvements. Technology facilitates progress. It's just like saying back 50 years ago, there were excellent doctors. They didn't have MRIs, they didn't have a lot of those things that we have today, but they still treated patients. They still got results. So don't depend on technology. Your science, your knowledge of the human body and treatment of understanding to why you're doing what you're doing is more important than what machines you have. Machines help bring outcomes, yes, I'm not denying it. But if your focus is on the machine and not growing your understanding of the patient's condition, you can use all the technology you won't improve. That's important, That's about it. Is there anything else, or is there any other questions?
Yeah, I do have a question. I'm very interested in the educational pathways that are possible to get to the different positions, PT, OT, PT assistant, OT assistant. Can you tell us a little bit about that?
Yeah, so with you can be PTA, OTA, they're called codas, I guess, and they're typically an associate's degree to start. So it's 2 years right out of high school. You go and you can get that, and you can immediately start working. They're then for PT school, OT school, speech, it's an additional schooling after you've gone through 4 years of college. So you go through the 4 years. OT and speech right now are just a master's degree. So right after you graduate with your bachelor's, you just have 2 more years and you can get your master's for both of those. Physical therapy has transitioned to a doctorate. So you come out as a doctor, and it's 3 years depending on which school you go to. The majority of them are 3 years. The program I went to was accelerated. It was 2.5 years, so it just meant that we worked through a summer, whereas other places didn't. And like I was saying about the transitional programs you can go into, you can get your associate's degree to be a PTA, and then you can work for a while, get your prerequisites that you need. Most of the time it's things like psychology, which is super important because you're dealing with patients all of the time. Psychology is a huge, huge thing to learn. Kinesiology, statistics, physics, because you're having to learn levers and pulleys, because our body is basically levers and pulleys. And then you go and get a transitional DPT. And so it's just 2 more years after you've gotten that PTA degree, because you already have a lot of the clinical side. You're just learning more of the diagnostic type of side of physical therapy.
I was wondering if there's anything less than 2 years. If someone really wanted to get into it right away and maybe work as they're going to school, is there certificates that are less than 2 years, or is 2 years the entry point?
2 years is the entry point. You can be a tech. Like some places allow you to be a physical therapy tech, and for that you don't need any type of certificate or schooling, and you're just kind of an assistant. You help around the clinic and do different things. The same thing if someone wanted to, our front office staff, we cannot do what we do without our front office staff. And our medical assistants. And so for those, that's something you don't necessarily have to have any certificate from. You can kind of go into work and do it while you're in school, as long as your schedule allows and that kind of stuff. And so there are different kind of things that we have in that sense to get into.
But just remember, as a PT tech, you don't get independence, and you don't get a patient where you independently handle the treatment. You are always having to either go through the help of a PTA or a PT.
Are there any other questions, either in the chat or unmute yourself and you can ask the question live? I don't think there are. Well, we want to thank you very much for joining us today. This has been very enlightening. You're making me want to sit up taller in my chair with my back. You're making me think about the way I sit when I do my work, and that's a good start, right? Is just the everyday, while you're healthy, the everyday things you can do to improve your physical health. And I want to thank everyone for joining us, and have a good day, all.
Thank you. Bye-bye.